Okay, this is a patient who had a pelvic mass, and there's two things that I wanted to share. One is a pelvic mass, which you see here. It's T2 dark. It's enhancing. I'll give you your post-con. Here's your post. Oh, the hypo-enhancing, but it is enhancing, but it's hypo-enhancing.
And is this a female? And where's
Yep,
their
it's a
uterus?
female. And what was your other question?
Where's the uterus?
The uterus is right there. Let me give you a sagittal. So it's extrauterine.
And where are the ovaries?
Oves are this is the other thing that I wanted to discuss. This was incidental finding, but oves, where did the oves go? So this one I thought was coming from the right neck side, because you can see here, I think maybe are the follicles.
Oh, that's
but
a cool
I see
stalk.
the gonadal vessels that are going to it right there. And then let me see if I'm showing the case actually for the incidental finding, but the left ovary, where did the ovary go? Did I see it? Yes, no, right ovary I saw, left ovary I saw as well. So,
but if we think it's coming from that right ovary, then we're thinking like fibroma.
yeah, exactly. That like along that fibrothecoma spectrum. Yep. And then, so the case that I'm surgical path is pending. The other finding that I wanted to share was this: the cystic T2 hyperintense cystic kind of findings along the course of the gonadal vessels.
Is that a lymphangioma in the retroperitoneum?
Yeah, exactly. So here's a really great case in the literature, and it looks just like it. How do I center it here? Okay, so this is a case report, lymphangioma surrounding the ovarian vein and ovary. Right there, you can see, similar, this is CT, but similar kind of cystic appearance along the course of the gonadal vein, and kind of extending to the ovary. And then here's some path images. And then we see the same thing on our case, but it's just more of an MR variant, or the modality is just a different, but it's the same thing. It's a lymphangioma along the course of the right gonadal. You can see it going into the right ovary here, right there. So it's just a really cool.
Beautiful. It almost looks kind of like an extension of the cisterna chyli. Like, when they do lymphangiograms and it crawls up like the whole retroperitoneum. It almost looks like that, but dilated.
See if I can get the
more
axial T2 large field of view. Okay, well, I have a fat sat version, but cisterna chyli is a little higher. It does look like a
right, and it
cisterna.
should be behind the cisterna chyli would be behind the IVC, but like retrocurl, but below that, like when they do lymphangiograms and they trace it up, it goes through some lymphatics, so it almost looks like those engorged ones. But okay, so this was a rectal protocol case. Stop on the area of the finding. So there's this T2 intermediate signal mass here. And then I'm going to show you the post-contrast. There it is on post-con, and it's measuring a little over 2 centimeters, which is kind of important. In a few minutes, I'll tell you why. That's the arterial phase, and then this is the more delayed phase. Any thoughts?
Well, I wanted to say rectal cancer, but it's enhancing and it's washing out like avidly.
Yeah,
so
like rectal cancer is usually not this avid, right?
Get some kind of vascular mass. So can I put neuroendocrine tumor in there?
Yeah.
I mean, I don't think it's our common variety. What else I knew?
Is it a MET?
Great thoughts. So it was not a MET. It was actually, but those are great. Those are both should be in the differential. And this turned out to be a neuroendocrine tumor.
There's
So-
something else at like 6 o'clock position on the T2, but maybe it was the artifact.
Right. So actually that was another important thing. If you go to the post contrast, you can see that really the tumor is only here. Whereas on the
Interesting.
T2, it was a
Yeah,
little
it looked like,
tricky. It
yeah.
looked, yeah, let me show you the
Yeah,
T2
there's a little bit
again.
more. Yeah, there it is. Yeah, from 4 o'clock
Right.
to
So this
6
was just
o'clock,
like
7
a
o'clock.
fake out.
Huh.
This was just
Interesting.
like stool.
Yeah, that's your evil girl right there. As
I
evil as it
know.
gets. But it's a
there's
fake
nothing
out.
there.
Yeah, interesting.
But anyway, so
I
I
actually
want to
find
just,
that the post-con is super helpful to delineate the boundaries of the mass, especially
yeah.
when you're looking for local invasion.
Yep. Yeah, here it is. See, there's nothing back here.
Wow, that's incredible.
Okay, so just a couple of points about rectal neuroendocrine tumor. First of all, the incidence is rising rapidly, and they think it's actually mostly because we do so many colonoscopies, and so a lot of them are incidental. And a lot of them are very low grade. And actually, recently, based on the SEER database, it's taken over as the most common site of neuroendocrine tumor, even more than small intestine. 80% of them are less than a centimeter. So often they're just like a tiny little nodule that they find on colonoscopy that they resect and comes back neuroendocrine tumor, and they're usually low grade. Another 15% are 1 to 2 centimeters. All of those that are less than 2 centimeters can usually be treated by just endoscopic resection, including some more advanced techniques where they dissect into the submucosa. But once they get to greater than 2 centimeters, they start having to do kind of more extensive surgery like LAR or APR. They kind of treat them like a rectal adenocarcinoma, and they have a worse grade when they start getting larger than 2 centimeters. I'm just going to show you this management algorithm. See if I can pull it over. Kind of nothing earth shattering, but what I was basically just saying is that like they're, if they're suspected at colonoscopy, they'll do a rectal ultrasound. Less than a centimeter, they're going to do an endoscopic resection. 1 to 2 centimeters, more advanced endoscopic resections. But if it's deeper involving, or if it's greater than 2 centimeters, they're going to do an entire surgery. So, and this was also the paper that said that they are now the most common type of neuroendocrine tumor.
Wait, what's the most common type of neuroendocrine tumor?
Rectal. For
Oh,
the
location.
gastrointestinal pancreatic tumors,
Gotcha.
the rectal is now the most common, even more than small intestinal tumors. Just
Got it.
because probably because we're detecting a lot of small ones incidentally.
Is there a breakdown of grade 3 like there is for pancreatic neuroendocrine tumor?
Yes. Yeah.
So that classification of like the one that is the prognosis, the worst prognosis, that's similar to like prognosis of pancreaductal adeno versus the kind of the more or less aggressive grade 3 with the Ki-67.
I think so, but I'm just looking at this paper. It's just, in this paper, they're just calling G1, G2, and G3.
Oh, okay.
But
So maybe
one of
there's
the
not a
main points
subtype,
is that
grade 3.
95% of them are going to be small and low grade. So a lot of the rectal, protocol MRs that I've read for rectal neuroendocrine tumor, I don't see anything because they found it incidentally in colonoscopy. They resected the whole thing, and now they're doing like the staging MR, but you don't really see anything left there. So that's the much more common scenario that I've had for, when I'm reading these MRs, but this was a much larger one. So they're actually planning to do an LAR here. Okay, and I have a companion case. Can you stop recording for 1 sec? Okay, so this is a companion case, and you can see that there's another rectal tumor. And in some ways, it looks kind of similar to the neuroendocrine that I just showed in that it's sort of round. It looks somewhat well circumscribed. So if you were reading this, what would you have said? This is the T2, and then I'll show you this is post contrast.
That has more necrosis. I mean, or
Yes.
like areas of non-enhancement. And it doesn't really like enhance and wash out in the same way that the first one, but maybe because it's just degenerating.
Yeah. So are you thinking rectal cancer? I mean, statistically, rectal cancer is still going to be the most common, but I will tell
I mean,
you.
tissue. I mean, tissue is the issue, right? Like,
Yeah.
I don't think we can buy MR. We can call it this or that.
There's a large exophytic component on this one.
Exactly. And we actually like see how there's actually
Yeah.
sort of like this endoluminal and exophytic component.
Yeah.
Well, as you're saying that, it makes me think, could we add gist in that DDX?
Yes, exactly. So this turned out to be a rectal gist. So just a really nice example of a rectal gist. This was biopsied. It came back spindle cell neoplasm. It was c-KIT positive. So that means that it will respond to Gleevec. And it was also had greater than 5 mitotic indices. So when you put it in the nomogram, it's actually a high risk gist. The risk is based on the location, the size, and the mitotic index. So when you put all of those in, this is a high risk one. And then also rectal gists are tricky to resect because of their location. You can see how deep down it is. It's pushing on the prostate. So they are currently treating this one with Gleevec to shrink it down to make the surgery easier, and because it was a high risk one as well. So post Gleevec, if you're reassessing this, you're going to use the Choi criteria and look for non-enhancement in this. It might grow in size, but that is commonly seen with GIST, but what you're looking for is devascularization. But yeah, just two cute little submucosal rectal masses.
Okay, this is a patient with elevated PSA and had this MR. So there's your T2.
It looks like vague and smudgy T2 hypointensity in the peripheral zone, but not really like cancer. I don't know.
Good. So here, and there's something in the left apex right here. And here's your diffusion. Here's your high B value. And then your ADC.
So it's like shining through. It's not really restricting on ADC.
So what do you think?
I feel like it's not dark enough to be granulomatous prostatitis. Maybe some other kind of prostatitis or infection.
And this was the follow-up.
Gotten smaller.
Yep, both. The left apical thing and then the right.
Some kind of inflammatory infectious
So this
thing.
this was prostatitis. And presumably granulomatous prostatitis because the patient was on BCG. So anyways, this is just another look. I mean, I think granulomatous prostatitis can have any look, to be honest. I think, so, and then this was the follow-up diffusion there, and then right here. Overall improving.
And show the bladder, because you said they're on
Bladder.
BCG for presumably for bladder tumor.
Here's bladder. Oh, sorry, here's a bladder.
Yeah.
Yeah, they've been getting like TU or BTs and stuff like that, but there's no current bladder mass that is apparent.
I have a question. So they did this prostate MR though,
Yes.
because presumably their PSA was elevated.
Yeah, and biopsy was negative.
Can granulomatous prostatitis elevate your PSA? Just out of
I
curiosity.
think so.
Okay.
I mean, I have to look it up just to confirm, but I think so. Just a fake out.
That was the first time I've prospectively called granule or
Prostatitis.
Yeah. I mean, aside from.
So this is a patient who has history of HCC. You can see that it was removed. And
I'm sorry, history of what?
HCC.
HCC, okay.
Hepatocellular carcinoma, my favorite cancer.
Yes, I
Okay,
just should have assumed it. I mean, I don't know why I even asked. Of course, there's a history of HCC.
So this is a CT from about 8 months ago. This patient's original HCC is 5 or 6 years ago, and I don't remember, she was followed and is doing great. So this is the prior. Okay, and now this is the case that I've read, and you can see that, patient does have, I mean, there were some patchy areas of, perfusional changes. But what caught my eye, let me take away the nod. You can see that there's a new kind of area of enhancement here, right? It's very ill-defined, right? You can see it was not there before.
Is there
Now, in the
background a little
prior-
bit of steatosis too? Or maybe not?
Maybe not. Here's the non-con. You can see
Oh yeah, it's
probably
yeah,
not.
no steatosis, yeah.
A very certain patient had Hep B. Anyway, but you can see that and the patient had like some prior like kind of patchy foci here and there that they said probably perfusional, like this one, and kind of still has that. So it has very geographic area, and I don't know. So I was originally going to dismiss it as a as a what do you call it, as just perfusional.
There's
But
also a
it's
little bit of
fairly-
mass effect. There's a little bit of like a concave margin, or maybe it's okay.
No, great observation. That's what I thought too, but it was kind of there before. So, I was about to dismiss it and going back and forth. It's just so big. I looked at it from on lateral and coronal projections, and really, I'm afraid to like make sudden moves because I don't want it to start to shift. So you can see here, it's like sort of geographic, and I just kept coming back and forth to it because I don't know, it's just so big. If you just randomly just put in big, right? Okay, so you can see however we turn it, right? It's just so geographic, right? So I was going to dismiss it, but it was just kept catching my eyes, just so big. And then eventually I got what I found. An actual little lesion. Now there's no Vorshad, but it's a real lesion. I looked it up, looked carefully, and you can actually see it a little bit on tree. So it was a real lesion, it was LR4. But I guess the teaching part here, if you see a new, little foci of enhancement and perfusional changes, they come and go, and it also depends on, on the, exact timing of our chill phase, so it can certainly change. If you see something really big, just really look carefully at the apex of the feet, this new perfusional stuff to make sure there's nothing there. And there it is. And yeah, so that was cute.
This is a nice companion to the one you showed last week with the pancreatic adenomets that were making perfusion abnormalities. Because it takes out the little portal venule, so the artery takes over.
I think that the one that I showed before was from fat sparing. But yeah. But anyway, any kind of new parenchymal changes, including new fatty sparing and new perfusion stuff, just be careful and make sure you scrutinize everything, and especially the apex of the area, just to make sure there's not like really in there.
And I remember like one of your talks, you talked about like how LR3, these little perfusion change and these enhancing things, like there's actually pretty high percentages that go on to become HCC within like a year or two, right? Like,
well, LR3s, yeah. So about 60% of them progress to 5 or M in 4 years. But LR3, like LR3s are different, right? So some LR3s have higher risk, some, so like this one, right? Theoretically, hold on, look at that for sharing. Right, so this one, if we just saw that without anything else, right? And it was the first time we were doing, we're reading the patient, so without the corona around it, you could theoretically say it's LR3, and potentially, right, like if you look here, like some of these look very similar, right? But the reason why this is not LS2, right, because A, it's new, so there's subspecial growth, and B, this big corona enhancement around it, that's actually pretty significantly that prognostic sign for the HCC.
Victoria,
So that's what's
there's-
bumping it from a 3 to a 4.
yeah,
then?
excuse my ignorant question, but is that an ancillary feature, the perfusion thing, like that would bump it up?
So that's corona. So there are two ancillary features here. A, there's subspecial growth. Actually, I was able to go back and find it on the prior. There's like a punctate thing on the prior that I'm afraid to bring up because it's gonna, hold on. Let me stop sharing. Actually, you can actually see that it was there before. It's a little bigger now. And the corona is new. So the corona is ancillary feature of malignancy, so you can bump up. And the fact that it's bigger, a little bit bigger now, that's another ancillary feature of malignancy.
Wait, sorry, just to clarify, coronal, you mean for the actual lesion, right? Not the perfusional, the geographic subcapsular perfusional changes?
So this thing is corona, right? Because it's around the lesion.
Oh, I thought the lesion was tiny. So
Yeah,
the
the
whole
lesion
thing is
is
a lesion?
tiny, and she's calling the
The lesion-
perfusional thing the corona. I thought corona was like a
Around the
rim,
lesion,
like a rim around the lesion, not necessarily
Yeah.
like a big geographic perfusional thing.
right?
It can be both, right? I mean, generally we think about it as a big, but here, this one is a big thing. Right, there's no rule as to what corona is, but this perilesional enhancement arterial phase is actually a pretty not great prognostic factor.
Like to me, that geographic subcapsular stuff is that, that shunting that Aarti described before that we see with tumors around, that caused by
Yeah,
the
she's
shunting.
saying that they both fall under corona, that description of corona.
Oh, interesting.
Yeah.
Even though corona means crown, so like it should be circular around
Right.
it. I guess the name is a little vague.
Right.
Clarification on the
have-
next update.
No, there is a perilesional perilesional enhancement arterial phase. So that's
Oh, got it.
kind of topic corona. So that would be that.
Good to know.
But anyway, but you have like there are things here, right, that tells you that this is not just a perfusional thing, right? Because you have a lesion and there's a new like perfusional crap around it, right? However you can call it, corona or whatever, right? It tells you that we're not looking at the little the rounded thingy itself. This thing is not just like a little perfusional thing. It's an actual lesion that's growing. And I kept coming back to it. So if something bothers you, come back to it. Okay.
So this is a patient post-UFE. You can see that they have these calcified fibroids. One of them has air in it, which is actually not that uncommon in the immediate or even long-term post-UFE phase. Usually it's from necrosis with nitrogen release. And you can see the bladder has some air in it. Bladder wall is a little thick. So this was the first scan that we had. And then we came back later. You can see that the bladder wall again looks thick. There's air in it.
I mean, there's something going on with the bladder and the uterus.
Yeah. So then we did
Like
a more,
visualized or something. Do you have a
exactly.
satchel?
So this is the more delayed phase. Hold on one second. Let me just move it up. So we've got an excretory kind of like super delayed phase. And we can see that
Oh,
there's contrast in the bladder, but also into this fibroid. So these areas were not enhancing before. And also now there's contrast in the vagina.
So did we hit the cystic artery? Is that what happened? Like, did we just necrose the posterior wall of the bladder, or did it just?
So yeah, that's what we think happened. So this is a more delayed. We can see even more contrast in the vagina, and then like or surrounding the fibroid. They underwent a cystoscopy, and this fibroid was essentially inside the bladder lumen. So this is a rare complication of UFE. I did find a case report here. So this was erosion of a Lamellated into the bladder after UFE. There's just been a few cases reported, and one of the theories is that it undergoes necrosis and becomes inflamed, and then also could induce neovascularity of like adjacent organs. So it's really rare. Usually if a UFE fibroid sloughs off or is moving, it gets ejected out of the uterus, but in this case, it actually eroded through the wall of the bladder. Yeah. So,
do you have the sagittal?
Uh-huh.
That's incredible. Normally the bladder is pretty thick walled, right? It's like a.
Yeah, I just think like, it can induce a lot of inflammation around it. So,
Yeah.
and it was a big one. And this UFE was actually remote, so it did take time to do it, but it was completely within the bladder lumen.
Incredible. Okay, this is a patient with this finding.
Cholangio. Or some kind
Cholangio.
of malignancy.
Okay,
But one thing
yeah.
that I want to point out is the left lobe is like atrophic and shrunken with a
yes.
bildil. So that means that the left
Mhm.
portal vein is out.
Left portal vein is out. Wait, I'm sorry. How did you get to the left portal vein being out? There is
Usually if-
bildil, peripheral, and there is atrophy. So, and this is a hemangioma here on the right side. I can show you the contrast enhanced later.
usually if the lobe is atrophic and there's like crowding of the dilated bile ducts, that means that the
Oh, gotcha.
vein is out.
Okay, yeah. So here's your, I guess this is more of a delayed maybe an arterial. This was surgically resected, and this was an IPNB.
With malignancy, not just like dysplasia.
I think there was not cholangio.
Isn't the malignancy that develops an IPNB usually cholangio?
Yes. Oh, yes. Sorry. Yes. Yes. I think like 70% of them go on to become cholangio. I think this was all just without cholangio though. Like the pathology
Just dysplasia.
Yeah. I don't know. Does IPNB like automatically mean dysplasia? I don't have the path report, so I can't really read it off of, but
No, IPNB doesn't automatically mean dysplasia.
dysplasia. Correct. Okay, good.
It's a
Good. Because
precursor
there was
lesion.
no evidence of malignancy within this resected IPNB.
Nice. That can be. Recently they have come up with two precursor lesions to cholangio. One is IPNB and the other is biliary intraepithelial neoplasia. So they don't necessarily.
Sorry, what's the difference again?
What's that?
What's the difference?
So biliary intraepithelial neoplasias are usually microscopic entity and they form as a carpet-like growth, whereas IPNB usually is polypoid and causes biliary ductal dilation more often than intraepithelial neoplasia.
So this is a middle to late age gentleman with prior surgical history. Sorry, withholding one of the things.
So a bowel obstruction and a gallstone. So it's like maybe a gallstone ileus / obstruction, but there's multiple sutures.
Curious in that the gallbladder has been removed.
Is it like an enterolith that just developed in situ
Right, so
in the small bowel?
That's basically the differential that I had, whether or not
Anastomosis, yeah.
this was a fecalith versus a gallstone that somehow stayed in there a while, even after the gallbladder was removed. causing an obstruction, and that's true. And the patient did have a surgery with this removed, and for some reason they didn't. I don't think they sent it to path, so I don't really know which of those two entities this is. The lamellated appearance makes me think gallstone, but there's case reports. This person actually has one of the surgeries they had was distal ileoresection for Crohn's. So there's a Crohn's history here, and Crohn's apparently can get fecaliths that could cause problems too. So I'm
Crohn's
not.
also increases your risk of gallstones
Yeah.
because of hemolysis or something.
So I don't know
Wow.
which one I'd say for sure is the truth, except like I said, the lamellated appearance makes me think, because most of the fecaliths I've seen are not quite as world appearance like this, but
I guess the secondary signs though aren't there, like air in the biliary tree.
right.
Yeah.
Yeah,
Wow.
I mean,
Cool.
yeah, I mean, there's the gallbladder's been out quite a while. This is like the only imaging I have, but I think that it's a remote history of cholecystectomy. So
Isn't that so frustrating when they don't send it to path and you're like, I've been waiting for the path.
yeah, I checked and I'm like, you know,
I always get frustrated with like fish bone versus chicken bone. And then my pathologists are like, we didn't even look at it. I'm like, what? I've been dying to know what kind of bone it was.
right, exactly. I was like, no, we just tossed that out. I'm like, toss it out. What are you, crazy? We need to know this stuff.
just need to know.
Anyway,
Awesome.
that was my interesting case of the day, I guess.
Okay, so that the surgical path for that left hepatic mass, it says left fragments of intraductal papillary neoplasm of bile duct, IPNB, or also known as biliary papilloma, negative for carcinoma. And then it says multifocal intraductal papillary neoplasm of bile duct, or also known as biliary papilloma, is the largest, which measures 5 centimeters. Additional foci of biliary papillomatosis present, multifocal biliary papillomatosis present, negative for carcinoma. Margins uninvolved. So I mean, I don't know what the process for pathology reporting is in terms of underlying dysplasia, but that was the interpretation.
Yeah, it sounds like they probably would have reported it if there was dysplasia. I just looked up a paper that said, I think this is a moving target because IPNB is like a relatively newer term, but 33% have low-grade dysplasia and another 40% have invasive component and 30% have high grade. So 30% of low grade, 30% high grade, and wait, doesn't add up. Oh, and then another 30% have invasive. So it sounds,
So there's dysplasia.
my impression is
baseline.
that a lot of them have some dysplasia in them, but yeah, that's a great case. And it's interesting that it was obstructing the bile ducts and taking out the vein, even though it didn't have dysplasia or adenocarcinoma.
Can you hear me as well?
Yes.
Okay, so this is just a companion case to the IPNB that you just showed, Nelly. And as you can see here, again, florid, dilated, left-sided intrahepatic bile ducts. Now, independently, separately, the patient also has a history of HCC that has been treated, but ignoring that, there was progressive dilation of bile ducts. And this has not come out yet, so we don't have surgical path, but they did do spyglass and brush biopsies, etc. And each time it shows mucinous secretions, and they haven't seen any dysplasia or any evidence of malignancy yet. But it's a fairly large lesion. So in the future, if they resect this, then it would be worth keeping an eye to see if there is dysplastic tissue here or any malignant transformation. But so far, this has stayed as just an IPNB.
And can you see any of the papillary stuff, or are you mostly just seeing the mucin?
So there are some T2 hypointense areas here, on spyglass, they didn't record seeing papillomatosis or papillary growth. And on the post-contrast, we don't see any enhancing components. Sometimes, you know how you see polypoid enhancing tissue within IPNB? We don't really see any enhancing tissue there. But on the T2, it's not a clean T2 hyperintense ducts.
Yeah, and I do like that there's these outpoachings. Do you see like those
Yes.
circular outpoachings? Yeah, so
Yes,
that's
right
much
there.
more suggestive that, and even centrally, like this is all more suggestive of a mucinous thing than just like dilated ducts because they're obstructed or.
Correct. And then this is what I was talking about. There are some T2 hypointents. They could be just debris because we don't see any enhancing polypoid tissue there. But I thought it was a nice companion case to what Nelly just showed.
Anu, what's up with those areas in the right lobe that are like kind
Oh,
of?
they've been treated.
Oh,
There's fibrosis and they've had HCC, so they've undergone ablation and separately treated for HCC.
got it.
It's always amazing to me how the mural stuff in these IPM can be so imaging occult. You know, we're struggling to see something there sometimes, and then especially when you
Right.
see
On final path, they probably do have something because something has to be creating the mucin.
right.
And sorry, I knew they were just surveying this, like it's not like standard to resect them,
I don't
or the patients just couldn't get a resection for
know.
comorbidities.
I don't know if it is standard to go ahead and resect when you see this. I have to read up on that. But currently they're surveilling. You know, they did get cytology and biopsies and they've been negative, so they're surveilling. I don't know if I'll bring that back. I'll read a little more and bring that back if it is standard to go ahead and resect. Since it's a relatively newly described entity, I don't know if it's standard to go ahead and resect.
Yeah, I think it's a big debate and discussion at tumor board.
Okay, so this is a patient who has past proven metastatic colon cancer. The metastasis was in the chest, on the supraclavicular node. So this was already proven to be colon cancer. And so this is outside study for staging. And so I was reading this, and so I'm reading this, right? This is the head, and then all of a sudden the duct becomes kind of focally dilated and just gone, right? And then when you look in the coronal, the same thing, right? It's not really dilated, you can actually see it, and then it kind of stops and you don't see anything. Maybe there's a lesion, it's unclear, right? But then if you look carefully, there's a lymph node right there, and then there's like a little fat infiltration right there. You can see it, right? So, you know, patient already has one cancer, what does he need another cancer? But since this was already outside study, I had the benefit of follow-up. And now you can see in the, so originally this was not described in the original report. It was done for staging. So then this is a follow-up. You can see there's massive biliary dilatation, right? There's like this very ill-defined mass in porta hepatis, and then here the duct now becomes truly dilated, stops at the same level as we saw it on CT. And here it is on coronal, you can see nice dilatation of the duct, and just kind of stops right there. You can see normal duct distance. So there's a lesion here, right there. And the same here, right there. So, yeah, it's just kind of. So we don't know.
You know, like the double duct sign. This is the 4 duct sign. So when you have like a high pancreatic tumor and you have 2 obstructed ducts above and then 2 normal ducts below, call it the 4 duct sign.
Right. So we're still waiting for path. I don't know if this is like a really unusual metastasis, it's possible, or if it's just a second primary. Anyway, but I guess the teaching point here is not to dismiss, just because patient has one really bad cancer doesn't mean that they can't develop another really bad cancer.
And they might have like
something
a
bad.
undiagnosed mutation, like a
Right.
genetic.
Anyway, so that's the case I want to show.
Actually, that coronal has, it's really nice to see all those like the evil gray around the flavoids. I find sometimes, yeah, exactly right there. I find it helpful with vascular staging on MR to look at the T2.
Right. I mean, they you know, the differential, you know, MR provided, you know, primary metastatic, but it's just behaves
It's
like,
actually crazy that the portal vein is still going through there, actually.
right.
It's still open, yeah.
Yeah. Anyway, so that, I guess we made it. Cool.